Hi there, I'm Dr. Fergal Armstrong. Here's a problem. We use the words tolerance, dependence, and addiction interchangeably, but they mean completely different things. This confusion creates unnecessary fear, prevents people from seeking appropriate medical treatment, and causes patients to be mislabeled. Today we're going to sort this out once and for all. Let's start with tolerance. Tolerance means your body's response to a substance diminishes over time, so you need higher doses to achieve the same effect. Here's the crucial point. Tolerance is a physiological adaptation, not a disease. Your body is simply adjusting to the repeated presence of a substance. This happens with many medications, not just addictive ones. For instance, if you start taking a sleeping medication, the first dose might work brilliantly. After several weeks, you might find you need a higher dose to fall asleep. That's tolerance. The same thing happens with blood pressure medications, antidepressants, even caffeine. Someone taking prescribed opioids for chronic pain might develop tolerance over months or years. They need higher doses to control their pain, but this doesn't automatically mean they're addicted. Tolerance can develop in people taking medication exactly as prescribed for legitimate medical reasons without any compulsive behavior or loss of control. Interestingly, different aspects of drug effects can develop tolerance at different rates. With opioids, tolerance to pain relief develops slowly, while tolerance to respiratory depression, the dangerous effect, develops faster. This is actually a safety feature built into our biology. Physical dependence is when your body has adapted to a substance to the point where you experience withdrawal symptoms if you stop abruptly. This is an expected, predictable outcome of taking certain medications long term. It's not a moral failing or a sign of addiction. It's basic physiology. Caffeine is the perfect example. If you drink coffee every morning and then suddenly stop, you'll likely get a headache, feel irritable, and struggle to concentrate. Those are withdrawal symptoms. You are physically dependent on caffeine, but you're not addicted to it in the clinical sense. The same applies to many prescription medications. People taking antidepressants, blood pressure medications, or corticosteroids can develop physical dependence. If they stop these medications suddenly, they experience withdrawal, but they're not addicted. In medical practice, we manage physical dependence through tapering, gradually reducing the dose over time. This allows the body to readjust without severe withdrawal symptoms. It's a completely routine part of discontinuing many medications. Physical dependence can certainly be part of an addiction, but you can have dependence without addiction. The critical distinction is what happens next, which brings us to the third concept. Addiction, or what we now call substance use disorder, is fundamentally different. Addiction is characterized by compulsive drug seeking and use despite negative consequences. The key word is compulsive. People with addiction have lost control. They continue using even when it's destroying their health, their relationships, career, and life. They want to stop, but can't. The diagnostic criteria for substance use disorder include things like taking larger amounts than intended, unsuccessful efforts to cut down, spending excessive time obtaining or using the substance, giving up important activities, and continuing use despite physical or psychological problems caused by the substance. Critically, the DSM-5 specifically notes that tolerance and withdrawal do not count towards the diagnosis when they occur in the context of appropriate medical supervision. Why? Because they're expected physiological responses, not indicators of addiction. Consider two patients taking opioids for chronic pain. Patient A takes their medication as prescribed, functions well at work and home, and experiences some tolerance over time. And when they decide to stop, they work with their doctor to taper safely. They have tolerance and dependence, but not addiction. Patient B started the same way, but over time begins taking more than prescribed, runs out early, seeks multiple prescriptions from different doctors, continues increasing their dose despite worsening function, and hides their use from family. That's addiction. Addiction involves fundamental changes to brain circuitry affecting decision-making, impulse control, and reward processing. It's a chronic brain disorder, not just physical adaptation to a substance. Understanding these distinctions matters enormously. First, if you're taking medication long-term and develop tolerance or dependence, this doesn't automatically mean you have an addiction. Don't let fear of being labeled an addict prevent you from taking necessary medication or discussing concerns with your doctor. Second, if you need to stop a medication you've been taking long-term, work with your healthcare provider to taper safely. Abrupt cessation can cause dangerous withdrawal, regardless of whether addiction is present. Third, if you're experiencing loss of control, compulsive use, and negative consequences, those are signs of addiction that warrant treatment. Don't minimize it by calling it just dependence. Finally, use precise language. It reduces stigma, improves treatment, and helps people get appropriate care. Not all dependence is addiction, and that distinction can literally save lives. Tolerance, dependence, and addiction are three different phenomena. Using them correctly isn't just semantics, it's the difference between appropriate care and harmful mislabeling. If you find this helpful, subscribe to MedHeads for more evidence-based health insights. I'm Dr. Fergal Armstrong, and stay well.